All right, thank you for coming, and thank you for staying late for those of us who jet-lagged. So today I wanted to tell you about our efforts of taking cellular senescence and bringing it in clinic, understanding is there a use for measurement of cellular senescence? Is there a clinical utility there? And so as we all know, cellular senescence is regulated by the immune system. So it's a very tightly regulated system. As cellular senescence cells accumulate, immune system can sense them and deplete them. And so you can have a situation where you have either too much input that creates too many cellular senescent cells, or your immune system is disabled from the surveillance. And so you can have a scenario where now senescent cells starts to accumulate. And when we initially thought about sort of measuring cellular senescence in a clinical setting, we were very set on capturing the entire system. So when I talk about cellular senescence, I really mean the entire system, both the cellular senescence and the immune system arm, because as you can see, it is extremely important to capture the entire system to be able to deliver on the ability to change cellular senescence. And so, we set out this goal of identifying longevity interventions that can change the senescence, so restore the senescence network to sort of the normal state in humans, right? And so there was absolutely, so this was about 3 years ago, there was absolutely zero data to go on. We could not design a study to be able to do this because no one ever done this. So the first thing we did is we measured cellular senescence and immune function in a cohort of 250 healthy participants across lifespan to just even see what's there. So what we found is, as you can see, there is extreme heterogeneity both in cellular senescence measures and in immune function measures, and somewhat gender specific for the immune function. And so this was really exciting because if we think about being able to change cellular senescence metrics and immune function metrics to have a benefit, the idea that there is a lot of people who have those vulnerabilities in this area suggests that they might, if we can identify the treatment might actually be very effective because there is a lot of people who can benefit from that. So it was super exciting. Being able to see how many people can have efficacy for treatment was super exciting. And completely encouraged by this, we said, okay, we're going to do this. We're going to design a clinical study. We're going to put in longevity medicine. We're going to collect treatment data. It's going to be great. So not so much, not so fast. We spent months trying to come up with the design. And it was really interesting for those of you who were here, it was really interesting to hear the X-Prize panel discussion on sort of these conversations they had in designing their X-Prize trial, because we almost had identical conversations of who do we enroll, who do we not enroll, what treatments to consider, what treatments not to consider, how do we think about the real world scenarios where people use multiple treatments, people change treatments, how do we incorporate all that to have the clinical utility but also be able to run it as a study. And so, so what I will describe to you is kind of the design we ended up using, and we'll share some thoughts and kind of observations and some case studies on the results of this. And now, by the way, the study is ongoing. And I hope there will be some value, there will be some lessons learned, and you can sort of, as you think about your own treatments and you think about your own studies, I hope you can kind of benefit from sort of our, trials and tribulations of using this in a real translational reality. So the measurement of cellular senescence and immune function, we collectively refer to as Sapere. And so the study was called Sapere Longevity Medicine Study. So we, as I said, we set out to design sort of your traditional hypothesis-driven clinical trial where we're going to have our endpoints and everything is going to be designed, everything is going to be fine, we're going to control for all the things. And what we realized that it could not be done. We cannot design a hypothesis-driven study that would maximize the benefits and allow us to uncover the most efficient treatments and also consider safety. And so after many, many months of discussion, we decided to borrow from engineering. And we used sort of this engineering approach to product design to design a clinical study. So what do I mean by that? So it's a very elegant and somewhat simple way of thinking about the product, right? So first you consider user need. What is important? What is it that the user wants? Once you have that, then you ask a question, so what would be your input? What change or what design characteristics needs to happen to meet that user need? And then what would be your concrete success metric? What is it that you're going to accomplish that you think will satisfy that need? And then output was the milestone achieved. Simple, right? And so if design output was achieved, great, you're done. If not, you go back to input, you iterate until you basically come up with a prototype that meets the user need, right? So how did we use this to set up the registry? So we decided that the user needs, sort of with the advice from clinicians, we settled on the user need is the ability to rebalance cellular senescence system by treatments that are both effective and safe. And I think we can all agree that that's probably the user need that sort of can be defined, at least in the current state. Design input was interventions and protocols that would decrease cellular senescence by at least 50% or more in participants where either cellular senescence or immune function were deregulated and were in need to be improved. So this design input was intentional because it left the choice of treatments to clinicians and their clients. And that accomplished two goals. So first of all, it allowed for the treatment matrix. It allowed for the use of drugs and supplements and lifestyle modifications and what have you that people will think will achieve the most benefit. And then second of all, it allowed for the art of medicine. It allowed for the protocol to be tailored to individual patient based on the clinical parameters, based on the vulnerabilities that identified. And we believe that this would have achieved the maximum efficacy while minimizing the chances of overtreatment. Again, if we're looking for can we do this safety and effectively, you want to consider both the efficacy and the safety. And so this sort of design input, on one hand, of completely just leaving everything alone, we believe was really what made this a huge success. And so, so this is the design we settled on. We put the study on the ARDD committee, set everything up, and just got out of the way. We left it up to clinicians to do this. Our teams that were participating in the study are absolutely amazing. Practices I led, they're guided by MD trained, sort of traditionally trained clinicians with decades of experience. A lot of them are internists or former emergency room doctors, so they have broad expertise in all sorts of areas of medicine. We felt, at the end of the day, we felt like there is really nothing else we can contribute that we can do better than somebody who is, first of all, seeing their own patients, but also seeing sort of it on a clinic level. And so we just held our breath and, prayed for the best. And so what was the output? Was a successful milestone achieved? And I wouldn't be here if the answer was no, but yes, this was very exciting. I was the first one to be surprised. Decrease in cellular senescence was completely feasible with longevity treatments that exist today. So what are the statistics? So we used, again, since there was no data to suggest how successful the current treatments are, so we used the first year of treatment kind of as a baseline. We benchmarked at what are the chances of cellular senescence decreasing in a kind of traditional setting where Sapere is not being used, or at least clinicians aren't familiar with it, so it's not kind of being used effectively, right? So in general, about 12% of clients saw cellular senescence decrease, about 12% increased. After additional year of testing and guiding the interventions by Sapere, 37% of clients saw their cellular senescence decrease. 37%. I, in my wildest dream, did not think that you can achieve 37% success rate in a population that is, by sort of traditional scientific and clinical terms, the trial is just kind of completely open-ended, completely real world, completely undesigned. It's just, we just let clinicians do what they do. I mean, it was wild, and I wanted to give a specific shout out to Joe Raphael. Raphael Medical was one of our first adopters of this Sapere. We've learned so much from him about longevity medicine sort of as a business, and also he was instrumental in study design, and we really could not have done without him. And so how was this done? How is this possible that you can do this with, again, we are not suggesting any treatments. You can use whatever it is that you think your patient needs. So here's how Sapere was used. So cellular senescence is in the purple and immune function is in blue. So you measure both, and you will have some patients where both levels are optimal. You will have some patients where cellular senescence is increased and vice versa, immune function is a problem. And you have a subset of patients where kind of both domains are impaired. And so once you kind of identify which group your patients belong to, then you start to dig deeper and you try to understand what can be causing this vulnerability. So for example, if you think about if cellular senescence is increased, you can think about all the things that we know induce cellular senescence, and you can think of, could that possibly be a problem, and can I address that? Same way, if immune function is impaired, you again can look at all the things then we know impair immune function, and again ask the same question, is it possible that your client has a problem in that domain? Then individualized therapy, then you go and you try to address that, and then you monitor and you see what happens. So broadly, I wanted to kind of highlight the therapeutic modalities that can be used to decrease cellular senescence. By no means it's an inclusive list. So generally the way we think about this is we think about them falling into three categories. The therapies can have direct senolytic effect, so they target senescent cells directly. They can have indirect senolytic effect, so you're optimizing the immune system that doesn't target senescent cells, and they can be preventative. So when we think about, well, at least typically when one think about senescence and depleting senescent cells, you would think that direct senolytic approach would be the best, right? It's the most obvious place to go. We saw something really interesting early on, which made us think that that's probably not the best way to go. And so what we saw is, again, it's sort of in a natural aging study, what we saw is that there is a lot of people, even at early ages, there is a lot of people who have just the immune dysfunction. They do not have, sort of only 8% of them have dysfunction in cellular senescence. So there is a lot of people who have immune abnormality that way precedes senescent cells accumulation. So later, you can start seeing increase in cellular senescence, and then especially increase in kind of, the domain where, both are deregulated. But this sort of the signal of immune system dysfunction way precedes cellular senescence, again suggesting if you're trying to optimize for efficacy and improve safety, you don't necessarily want to use direct senolytics in patients who don't have senescence problem yet, but you might want to target immune system instead. And so how one can do that? There is a number of indirect senolytic methods, very hot area, so there's a number of indirect senolytic methods that are being used, and I'm sure we'll hear more about this. One of them is, for example, NK cells. So in this particular study, autologous NK cells were infused in 3 individuals, so 3 individual participants. You can see that infusion of NK cells decreased cellular senescence in a dose-dependent manner. So depending on the dose, in either 3 months or 6 months, cellular senescence was decreased, but then unfortunately it rebounded, showing that sort of delivering these cells was effective but was not sustained. Another way is SGLT2s, with a very exciting study showing that SGLT2 inhibitors can be senolytic by improving T-cell exhaustion, independently of its ability to regulate glucose. Rapamycin, John Manning showed that a decade ago, that rapamycin, again, can target the T-cell exhaustion to improve immune response. Beta blockers can target T-cell exhaustion. And on the preventive front, decrease in mitophagy is essential for establishing of senescence, so things like NAD precursors and rapamycin can also be preventative. So, again, to summarize, 3 classes. Like I said, direct senolytic seems to be an obvious approach, but as much as high cellular senescence in the peripheral blood may be bad, we also know that low cellular senescence is a risk factor for heart disease and cancer. And therefore, we really don't know if decreasing cellular senescence to those levels with things like sort of traditional senolytics, whether it will carry the same risk. And so therefore, at least at the current state of affairs, it did not seem like it was a good way to go. So we thought that indirect senolytic approach probably has the most rate of success. And again, by providing sort of a more physiologic way to clear senescent cells, less likely to go outside bounds, healthy bounds. And but keeping in mind that infusion of like immunocompetent cells, for example, might also be transient. So things that restore immune system, let's say by T-cell exhaustion, might be better. And then again, with preventative would be amazing. Like we should all be preventing senescence, right? But in a study setting, it would be almost impossible to demonstrate that senescence can be prevented in humans. Therefore, it would be really hard to collect the data. And so I want to touch briefly on the immune longevity score that we use as immune marker. So it's a machine learning algorithm that combines a lot of things, but it basically captures the T-cell exhaustion, T-cell production, autophagy inhibition. And when we report the Sapere metrics, when we report cellular senescence and immune longevity score as a top value, so first of all, kind of we report that so you can kind of place your patient in a category where it needs to be. But then we also report on T-cell exhaustion, autophagy, and T-cell proliferation. So again, clinicians can see further down molecularly where the potential vulnerability coming from. And so if T-cell exhaustion is a problem, for example, there might be therapies that can address that. So in the last few minutes that I have left, I wanted to show you a couple case studies that will, as completely unguided the registry was, as completely sort of the open study design was, things will get even more complicated. And I hope we all start to appreciate how this is a really complex and it's going to get even more complex really fast. So here's a case study of rapamycin. So a participant is a 51-year-old female, no comorbidities, metabolically healthy, sort of for all extensive purposes, a healthy participant. So she went on 5 mg of rapamycin. So within 5 weeks, she started to lose weight, and then by 16 weeks, she lost about 11 pounds. She was exercising during rapamycin treatment, so this is actually all fat loss. There was 0 loss of lean muscle, in case anybody's wondering. And so during that period, there was kind of initial drop in cellular senescence, but kind of basically rebound. So we would say there was really no change in cellular senescence. And there was no change in T-cell exhaustion, which John showed was the target of rapamycin. So there was 0 change in T-cell exhaustion. During that period, she self-reportedly reported increase in cognitive function, ability to recover faster from exercise, and kind of decrease in general inflammatory state. And so then there was a washout period, and then she went on a second round of rapamycin, but this time she went on 2 mg, and there was no change in weight. There was no change in senescence, and T-cell exhaustion was changed by half. So now she went from 20 percentile, which really wasn't high in the first place, now she's at 11. And that response was maintained for up to, I think, 18 months after the treatment was stopped. So this is a persistent change in T-cell. It's almost irreversible, I would say, change in T-cell exhaustion. And so I hope you appreciate how you have the same drug, the same person, but one dose can move cognition and, let's say, BMI, and another dose can move immune function. And so during the same period as she became a client in the longevity medicine practice, it was found that she has hyperlipidemia due to elevated levels of ApoB. And so when we learned that, we looked at vascular inflammation markers, and what we found is that at 5 mg rapamycin weekly, her vascular inflammation also decreased by almost half. Again, 5 mg was effective in decreasing vascular inflammation, but not at restoring immune function. And so things will get really complicated really fast, especially if you're looking at multiple endpoints. And I hope people sort of who are thinking about participating in X Prize kind of take that message and think about it, because that might very well be, and this is the same person. This is not population level. This is the same person. So things will get really complicated. And then so what about lifestyle interventions? We all know lifestyle intervention is the easiest way to sort of kind of buy yourself longevity, right? And we know exercise is great. So this patient was a new patient to the clinic, described as picture of health, healthy BMI, exercises, all good things. So molecularly, her T-cell exhaustion was insanely high in the 80 to 100 percentile, same with cellular senescence. So basically, her longevity protocols were not working. Every test was just high. Whatever she was doing was not working. She is endurance athlete, so she got injured and then was forced to sort of modulate her exercise. And then within a few months, her exhaustion dropped from 100% to 50%. During that same test, her cellular senescence decreased a little bit, but nearly not as much, obviously. Interestingly, in a subsequent test, cellular senescence dropped by half, suggesting, again, that there is this sort of immune system senescence network, but there is a time delay for the immune system to be able to do this. The fascinating thing was that her T-cell exhaustion actually went back up. So again, whatever longevity protocol she's practicing is damaging her T-cell function. And so we expect that if this does not change, then at the next test, her cellular senescence will probably go back up. And so it's monitoring this and being able to see this is really important. And I'm just going to stop there. Amy and I, this is Amy, this is me. Amy and I are here, happy to answer questions, happy to think about your design.
Thank you so much, Natalie. Really